Unmute. That would unmute. All right, I'm sorry. Okay, starting over from the very beginning. So learning objectives, for those who weren't in the room, and I was basically giving a little verbal introduction, this presentation is not designed to be some a state-of-the-art review of viral and fungal infections, and I'm not covering COVID. This is part of a lecture I've given for a number of years in a row at the American College of Chest Physicians annual pulmonary board review. So the format is designed for board review, not so much nuances, discussions about various infections, nor is it state of the art. So these are the learning objectives. Describe the clinical spectrum of various viral and fungal infections and pulmonary diseases. Outline some diagnostic strategies for viral and fungal diseases. Recognize the fungal morphologies that seem to be so important on board examinations. List treatment options and recognize key features of CMV, varicella, and herpes pneumonias. So we're going to talk about influenza. This is probably the first year in my career I've never seen a case of influenza in the winter. Nonetheless, it will be on your board examinations, and it will be back next year, is my suspicion. So classic manifestations: acute fever, onset myalgias, many very similar to COVID. And actually, there is a small percentage that do lose sense of smell, but nothing pathognomonic, nothing classic and super diagnostic. Tends to be large droplets, so regular surgical masks are plenty with an incubation of 1 to 4 days. Shedding for 0 to 10. You can see here, this is a nice graph of when you get inoculated, when you're at your highest titers, and how long it takes until you're probably no longer super infectious. The key things that show up on board examinations aren't this. It's what are the complications? And the big one are secondary bacterial pneumonias. So, and that's often a community-acquired MRSA. That's the scariest one. Strep species. You can also get complications are myositis and rhabdo. We see this occasionally, pericarditis, and a variety of CNS manifestations, including encephalopathies, encephalitis, transverse myelitis, this is some of the scary ones, and even some Guillain-Barré. So those are the types of things that might show up. Diagnostic tests, the best ones, and a lot of these are starting to fade and not even become available. It's the PCR. You get this high turnaround. It is very high sensitivity and specificity. It's the one that the CDC is recommending. All PCR tests have had a huge explosion in their performance, decrease in their cost, increase in their availability, and it's rapidly becoming the way to go and diagnose acute respiratory infections. The BioFire is one of the products out there now. I don't get any, it's a trade name, and I don't get any resources from them, and that's the one Henry Ford uses to run their serologies and PCRs quickly. Get a diagnostic evaluation. Before that, it was all these weird viral titers, and I am desperate to see a breakdown, not so much in 2021, but from 2019 or next year on what are the viruses that cause people to get sick in the winter? Because normally we don't test for any of them. And this is an old paper. This is from 2014. That showed a breakdown when they actually did some surveillance cultures in a community. This was at in Chicago at Loyola. And you can see rhinoviruses were the biggie that year, with some influenza being less common, mycoplasma, a human metapneumovirus, and a variety of others. To me, this is fascinating epidemiology, and I wonder how much variation there is year to year. I think as we move forward, we'll have better clues to this because it's so much easier to test for all of these things now. Treatment for influenza, if you have a confirmed or highly suspected case, within 48 hours of onset of symptoms, that's the key thing. It might help. It can reduce some symptoms. It might prevent you from getting too sick. The key is it's got to be given early. The problem is it's the only thing we've got. And so even professional societies are liberal in their use of a variety of antivirals. It's a little disappointing that they recommend treatments where there was no proven benefit, and that i.e. beyond 48 hours onset of symptoms. But sometimes when you're stuck in the ICU, one of the justifications is, well, you got a patient who's sick in the ICU with some influenza. You have nurses and RTs and docs going in and out of the room, potentially serving as a vector to the patient next door. maybe if you use these treatments, you lower the patient's viral load count enough so they're no longer that contagious. So I go, that's a nice theory. Maybe it's true, but is that justification to use one of these agents? I don't know. Here's a pearl. Zanamivir, don't use in asthma and COPD. These people get a little bit more problems when it was studied in the asthma COPD population. Prevention, standard stuff. I'm not going to go through this too much. Then we'll talk a little about some of the vaccinations for flu. And this is rapidly evolving too. Inactivator to recombinant influenza vaccine. This is typically what we get. If you're younger, you're eligible for the live attenuated vaccine. This is the intranasal one. That actually prevents you from actually getting sick and getting infected because it develops mucosal immunity. And so you can be exposed and nothing happens. The regular shots that we get, you could get the infection. You just tend to have mild symptoms or no symptoms, but you could still get infected. So, but the problem is this is not reliable. The live attenuated is not as reliable uptake of immunity in older populations. Older is 50 and age and older. Some people argue that you should get both, right? But for this, that's currently the CDC recommendation. The trivalent and quadrivalent vaccines, looking at all the different potential serotypes that they think are going to be the dominant species for the upcoming season, are becoming more and more common. And I've got this little cursor that's blocking. There we go. The CDC recommendations vary year to year in terms of which strains they're going to develop. And increasingly, we're learning that if you're somebody who's very good about getting your vaccine year in and year out, that vaccine you had 5 years ago probably still helps next year based on nuances in terms of how the strains evolve. So I'm a pretty big believer in vaccines for influenza. And after, 20 years of getting it, I hopefully I've got some pretty good immunity. All right, herpes pneumonia, moving on to the next virus. So this is pretty rare in immunocompetent patients, but it's obviously a significant problem for people who have compromised immune systems. Various diagnostic methods, viral cultures, PCR, and serologies. You got to be careful when you detect HSV from respiratory secretions because sometimes it can be very difficult sorting out a true pneumonia from from what's just contaminated from the upper respiratory tract. And then you can also have you can have reactivation without any parenteral involvement. So it has to be done in clinical context. So it's not a reflex. If it's present, treat. It doesn't work that way. Varicella is a fascinating pneumonia. It's incidence in immunocompetent hosts, 1 in 400. And you can get pretty sick from this. The risk factors, being a cigarette smoker, if you're pregnant, if you're immunosuppressed, and for some reason men do worse than women. It's pretty insidious development 1 to 6 days after the skin rash. Early acyclovir may help. The steroid role is controversial in these patients. But luckily, we're not seeing as much of it anymore, and that's because there's a vaccine. And so kids and adults are getting vaccinated against varicella. It's less prevalent in the community, and so we're seeing less varicella pneumonia, which is a good thing. Vaccines for susceptible healthcare workers with no history, probably 2 doses, and there's the zoster immune globulin for exposed adults. The key thing for this is it is probably the most infectious agent that we will encounter. It makes tuberculosis and SARS look like nothing. This is like one little cough and you're all exposed, right? It's the chickenpox factories, when the parties would parents would want to get their kids, get them their chickenpox, so let's get it over with, and they would bring their kids over. Seriously, this went on 20 years ago. May still go on today rather than vaccine. And you just put them in a room with one kid with chickenpox, and they'll all get it. It's super contagious. So you need an N95. The key thing for us in healthcare is if you are a healthcare worker who's female and considering getting pregnant or getting pregnant, you may not go near these things. It is horrendously teratogenic, and you should not be involved in the care of any patient with a varicella pneumonia. Okay, that's the key thing. N95s, double up. Here's some examples. So here's the skin manifestations. It looks like little pustules. There's a classic chest X-ray. It's a little, looks like micronodular throughout the lungs, and the CT brings it out even better. These tiny little nodules just everywhere. It's a pretty impressive radiograph in people who get sick from this. All right, now we're going to move on to fungal. That was the main purpose of this talk. And before we get started, a little review on some terminology. So there's yeast and there's molds. Yeast are the single cell fungi, and the molds, those are the multicellular hyphae. And fungi come in both forms. And you can have dimorphic fungi. So they can be yeast and spherules at 37 degrees inside of us, but out in the wilderness, out in the forest, and in the soil where a lot of these infectious agents come from, they're in the form of molds, and they're molds at 25 degrees centigrade, yeast and spherules at 37. So they're dimorphic based on temperature, how much carbon dioxide is around, pH, and cysteine levels. These are all things that influence the morphology of these things. So here's a nice little picture of some yeast, and this might be a mold format. So here's what we're going to try to cover. And I put these fungi, they're not my favorites, and my favorite, this is alphabetical, so I'm not playing favorites. Aspergillus, Blasto, Candida, Coccidioidomycosis, Cryptococcus, Histo, Mucor, Pneumocystis, and Coccidioidomycosis. And I will not spend equal time on each. Some are more important than the others. And for each one, what we'll try to do is look over, okay, what's the reservoir? Where are they coming from? How are they transmitted? What are the risk groups? What are the clinical features of these infections? Diagnostic strategies and treatment. So I'm going to start with an audience response question. We don't have audience response, but you guys can answer privately yourself. So a high clinical suspicion for invasive pulmonary aspergillosis, IPA, should be present with all of the following features except prolonged neutropenia, fever refractory to empiric antibacterials, positive to galactomannan and antigen test, pleural effusions, sinopulmonary tract involvement. All of these true except for one. So think privately to yourselves, commit to an answer to yourself. It's a key step in adult learning theory. Those who've rounded with me have heard that. Okay, you got your answer? Okay, the correct answer is pleural effusions. This is an uncommon feature of pulmonary aspergillosis, invasive. So here's a little picture of invasive of aspergillosis. These tend to be, I'll cover the morphology in a second. It's in the dirt, it's in soil, it's in organic matter. That's typically where it lives. We get exposed to it all the time. We inhale it in its filamentous form. There are over 200 species and the number are growing, but the ones that are most problematic to humans are Fumigatus and Flavus. Those are the two most common species that get us sick, less commonly Niger, Pteris, and versicolor. So lots of different species. We all get exposed to them pretty regularly. And this is one of my favorite graphs for Aspergillus because it kind of outlines, it's a weird fungus and what it can do to us. And what it can do, the clinical manifestations, there's lots of different diseases it causes. Same damn fungus causes all these different diseases, kind of dependent upon the host's immune status. So if we look at ourselves here over on the left, you have a normal host, we get exposed to it like we probably do every day during the summer, walking outside. We don't get sick. We have an immune system, yeah, we're good, right? If we have pre-existing cavitary lung disease, say from some old burnt out sarcoid, stage 4 sarcoid, just an old cavity or old TB, we don't see old TB much anymore, but just some old cavity, old big bullseye, that's a great place for Aspergillus to set up shop and grow just there. And when it does, there's all kinds of debris that forms and you can form an aspergilloma. It's a fungus ball with a healthy, otherwise normal immune system. So pre-existing cavitary lung disease, think aspergilloma. If you have some mild immunosuppression and some chronic lung disease, you're at risk for developing a chronic necrotizing form of Aspergillus. This is the classic pneumonia that just won't go away. That's again pneumonia. They were in clinic last week. I gave them some antibiotics, and they're back. It's still there. I'm not sure what it is, but it's not getting better. So it's a little smoldering, kind of looks like an infection, but just doesn't respond to that. And the folks, we'll talk about that a little bit, who's at risk for it. The ones you really worry about are the folks who have really significant immunocompromised systems. Classically, it's neutropenia. Neutropenia far more than lymphopenia or T-cell suppressed conditions like transplant recipients It's the neutropenic patients who are at highest risk for Aspergillus. And they get the invasive form. And this is the scariest, very rapid, life-threatening infections. Then there's on the total opposite end of the spectrum, adult who might have asthma where their immune system's a little revved up. They get problems with like an allergic reaction to the fungus, which is what ABPA is, allergic bronchopulmonary aspergillosis. Because the treatment here is suppress the inflammation. The role of antifungals is marginal. The key is you got to suppress the inflammation that they cause. It's like an allergic reaction to the fungus. So different diseases based on the host's immune status. So we're going to spend a little bit more time on invasive pulmonary aspergillosis. This is probably the scariest one and the one that tends to show up a lot on board examination. So I mentioned it can be in the sinopulmonary tract, including tracheobronchitis. Classically, fever, cough, sputum. If it's not recognized, not caught, not treated, about a 50% mortality. It's the vascular invasion where it gets its name, and this shows up. It can cause some pleuritic chest pain when you have erodes across the pleural surface and causing infarcts. It can erode in cross-tissue planes and cause hemoptysis. It can spread hematogenously, and it loves to go to the brain. And as I mentioned, neutropenia is the biggest risk factor, and it goes up each day. Although I say that it's the biggest risk factor, but up to a third of cases are not neutropenic. They're on some other steroid or chemotherapy or receiving something else. So this is what it looks like on an X-ray. These are bad IPAs. These are good IPAs. You have a large density here, and then there's this ground glass periphery to it that looks like a halo, and that's one of the, you hear that term sometimes used by radiologists, a halo sign. And then they go, think aspergillosis. There's other things that do it, but this is classic for IPA. So the diagnosis, you got to have a high index of suspicion. You got to be thinking of this. The histology is the best part, and this is the kind of, in terms of making a diagnosis. The classic thing you look for when you see this on the microscope is the branching angles are acute. And you'll often see tiny little septi at various places, pauciseptated acute branching hyphae. That's aspergillosis most of the time. There are some other rare fungi that can do that, look that way too, but this is the classic one. Cultures grow rapidly if they're going to grow, but the problem is they're very, very poor sensitivity. Sputum has a little bit higher sensitivity than the blood on cultures. More and more, we're looking at beta-D-glucan assays, and probably the best test is the galactomannan. And in fact, we have this is Fungitel, this one. It detects a cell wall component, but the problem is it's not specific to Aspergillus. It can cross-react with other fungi as well, and it also can cross-react with certain antibiotics, particularly the beta-lactams. And so all these patients seem to be on piperacillin, which can give you a false positive Fungitel. So you have to be careful with that. The galactomannan is probably more specific and more sensitive, particularly if you measure it both in BAL, if you've got a BAL sample, and in the blood. Those are currently the recommendations when you have a high index of suspicion is measure it in both if you can. And there's not a cutoff above this level, there's clearly it below it, it's not, there's a little gray area. An index greater than 1 has pretty good specificity, greater than, should be 0.05. Ooh, it should be 0.05, has better sensitivity. And you can also get false positives. Beta-lactams can give you a false positive galactomannan, as is a diet high in rice and pasta. We really don't use plasmolite, but that's been known to give false positives as well. When you bronch these people, the sensitivity gets better. On the fungal smear, its specificity is very good if you see it on a BAL, but again, it's low sensitivity. You don't need to do biopsies anymore. We used to, when I was a fellow, we used to have to get biopsies when we were looking for invasive to show tissue invasion of the fungi. These serologies, galactomannan assays, really have kind of made that unnecessary. So there's a bunch of published series on sensitivity of the galactomannan in various groups, and you can see these populations here in various sensitivities and specificities. This is getting better and better. So this is why Current guidelines are if you suspect it, definitely measure it in the blood. And if you've got a BAL sample, check it there too. And if it's positive in the right clinical context, it's probably real. That same principle applies for PCR testing. So now PCRs are exquisitely sensitive. The problem with PCRs is they can't differentiate live fungi from dead fungi. So that's a clinical judgment call too, is still the current guidelines from a nice ATS IDSA recommendation from about 2 years ago, a year and a half, was that measure PCR in both blood and BAL as well. And in the right context, if something comes back positive, treat it like invasive pulmonary aspergillosis. So this has taken an increased role. Don't measure in everybody, because if you'll have a bunch of false positives, you'll pick up dead fungi that are not relevant, but in the right clinical context, believe it, you don't need to do any more. So the diagnostic strategy, we get chest x-rays, they're non-specific. We can see some round densities, rarely some pleural-based infiltrates, and they sometimes cavitate. The pleural effusions are uncommon, as I mentioned. CT scans are more helpful. Often it's multiple nodules. I showed you a CT with the halo sign, and that perimeter on the halo is really from blood. As this fungus infiltrates and invades, that's where it gets its name, the tissues, it causes local bleeding, and that haziness surrounding the cavity is blood. And as it matures and wants to cavitate and form this air crescent sign, that's another term you'll hear on the radiologists, and this is all from tissue necrosis. I think I've got some images here. Here we go. Here's a halo sign. So here's your aspergillus here, and this is all the tissue, the blood in the surrounding tissues that creates this halo. Here's this over here. Now this is an air crescent sign because it's this little crescent of air, and you could say, well, let's look at that. I go, well, couldn't that just be a pre-existing cavity with a fungus ball in it? It's not an aspergilloma. Yes, unless there wasn't a pre-existing cavity. This is a new. If this is new, it's all new, and no pre-existing cavity, then I worry it's more of an invasive. And usually the clinical context will tell you that too. But that's the air crescent sign, this little crescent rim of air. That is not pathognomonic for IPA, but when you see that, you should think of it. Here's some more pictures, because pictures show up on boards. This is that, again, a halo sign around the lesion on a CT scan. This is my favorite image for aspergillosis, because this is really good. Acute angles, and you can see these little branches in between. This is classic for invasive. And then these two below, these path slides, show the hemorrhage as well as the fungus invading into surrounding tissues, where it gets its name, invasive. Yeah, why you need to learn these has always been a puzzle to me. I don't know a single pulmonologist in this country that has to look at their own path slides to make a clinical call. But some things die hard, right? So and so it's kind of silly, but they will show up on your boards. Okay, which is the current first-line treatment for a patient with invasive pulmonary aspergillosis? Fluconazole, Ampho-B, Vori, Itra, Caspofungin. You're probably going, oh, where's the Nizlafungin? Where's that? I don't see that. Yeah, I'm not giving you that one. Got your answer? Vori. Okay. This is based on one of the rare prospective randomized clinical trials for fungal infections that showed a clear benefit of voriconazole over amphotericin in terms of treatment for invasive pulmonary aspergillosis. So this is now 20 years old. So it's not even, this is not new news. This has been around for a while. So, and what's happening more and more is new antifungals are being compared now against Vori, showing equivalence. And whether it's cost, ease of administration, IV versus PA, all they have their little nuances and things that they market. But nothing's been shown to be superior to voriconazole since then. So isobucanazonium, this is the one, this is the prodrug that's now approved for both IPA and Mucor. We use a lot of POSI for this in terms of, and they've marketed in terms of prophylaxis. So, if you have these high-risk patients with AML or multiple myelodysplastic syndrome or GVHD after allogeneic transplant, these high-risk patients who are going to be immunosuppressed for a while, they've shown that regular prophylaxis with dosing of POSI can reduce the incidence of IPA. All right, less acute than IPA is the more chronic necrotizing form. I mentioned this is the pneumonia that just won't go away. The treatment is very similar. The key thing here is eliminating the risk factors if you can. Same diagnostic approach. You just have to think that this could be a chronic necrotizing form. We talked about the aspergilloma a bit. These are often asymptomatic, and when they are, you tend to leave them alone. But we typically get called when they start coughing up blood. And you go, well, how does it cause blood? It's not invasive. What it does is you have this aspergilloma sitting in a pre-existing cavity, and yes, they move. They bounce around. Every once in a while, you'll have a patient who tells you, I feel like something's moving in my lungs. Every once in a while, they'll tell you that. But what it does is as it bounces up and interferes and irritates the juncture of the opening to the cavity, where the bronchus and the pulmonary vasculature, right there, right at the opening, and bumps up again, and it causes inflammation. And it can erode in and cause those pulmonary arteries and veins to bleed. And they bleed into the airway, and they cough up blood. And they can bleed a lot. So the 2 times I have had patients die during a BAL, it was an aspergillosis. They bleed a lot. So when I see hemoptysis in an aspergilloma patient, I get nervous. And so we treat them like other hemoptysis patients, and now we have really good bronchial artery embolizations, which have a high degree of success. But this is how they bleed and why they bleed. It's not an infection causing the problem. It's usually irritation right there at the junction of the bronchus and the cavity. So if they're asymptomatic, you leave them alone. Some people have advocated itraconazole like for a year. The effectiveness is, yeah. If I had one and I had otherwise good lungs, just cut it out. If it's causing problems, just resect it and be done with it. And again, bronchial arterization, that's more of a temporizing issue. Sometimes it works long-term, but for people who have recurring problems, consider a surgical resection. And then there's ABPA. So these are the high revved up immune system patients. This is a non-invasive, more of a hypersensitivity disease. It can manifest as fever and pulmonary infiltrates, but it's not necessarily infectious. Mucus plugs are common. And the 2 patient populations where you really need to think about ABPA are those with refractory asthma. You've been on steroids, they just don't get better with steroids. There's something wrong, I don't know what it is. Do we use a biologic? In the back of my mind, those are the patients you need to worry about ABPA. And then CF patients. Those are the 2 big populations that get ABPA. And your goal of treatment is really preventing these exacerbations. The key treatment is the steroids plus or minus some itraconazole. But the key steroids are the key things. There's some debate on whether you should follow your serial IgEs or not. But clearly, this is the kind of thing you want to be thinking of and recognize when it's present. It's a tricky diagnostic criteria. I have difficulty memorizing this because I think it's a bit loose in terms of what it takes to make the criteria, but nonetheless, this is what's published in the literature. There's major criteria and minor criteria. Major, you need both present. You need a skin test or elevated IgE levels against fumigatus, and you need an elevated total IgE. And you need 2 of the minor criteria, which can be precipitating antibodies or a serum elevated Aspergillus IgG, radiographic opacities, or a peripheral eosinophil count more than 500. So 2 of these, both of those. Weird. It's loose, I think. I doubt you get nailed on that on a board exams. That's the kind of stuff here in clinic. And you're going, do I call this? That's when I look this up and say, yeah, I'm going to call it. Okay, blastomycosis. We'll see how many we get through here. So, do you guys see much blasto here in Michigan? I don't remember seeing much. We saw a little bit of it in Indiana, but I think the further south you go, this is the geographic distribution of endemic areas for blasto. And technically we're here. But anyways, it is endemic in the soil. It's a dimorphic fungus. We inhale it, we get sick, and it can cause some interesting problems. The clinical manifestations can be anything, and they can happen to anyone. You get a mild to life-threatening disease. Anybody can get it. Usually people present with what looks like to be a chronic pneumonia. So it's like chronic necrotitis and Aspergillosis. It's that pneumonia that just won't get better with antibiotics, right? Think in the back of your mind, blasto. So imaging can be almost anything. Here you have a cavity over here, but this one is, full-blown ARDS looking CT. The skin is the second most common site of infection. So they go, oh, we got this pneumonia, and then they show you an ulcer on the skin that looks like this. You should start thinking blasto. So obviously the disease severity tends to be worse the more immunocompromised you are. So the pearls here are things like anybody can get it. Just think of the skin. Best way to make the diagnosis is a combination of urine and serum antigen testing. These antigen tests get better every year. They do cross-react with some other fungi, but in general, they're pretty good. BAL is probably the best. We, for decades, have used serum antibody tests, both immunodiffusion and COMFIX, but timing and when you get them varies, and they can have fairly low sensitivity and specificity. Cultures, if you can grow them, that's the gold standard, but again, the sensitivity is low. And they're working on a DNA probe, but that's not yet confirmed. So the microscopy is great if you can see it on a smear. And so basically, to make your diagnosis, ideally a combination of all of this and the right clinical picture, and then you can make your diagnosis. And the classic question on the boards is: a middle-aged male returns from a hunting trip in Arkansas, out in the woods, Arkansas. He's got respiratory illness and infiltrates that doesn't respond to antibiotics, and his dog, his hunting dog, gets sick too. His dog's gonna get blasto as well. So here's a picture of it. To me, that looks like a bowling pin. You go to the bowling alley, it's broad-based. And so to remember blasto, broad-based, budding, this is the budding yeast, Bubba, the dog, equals blasto. That's your little memory device that you can use when next time you have to take your boards. Treatment depends on severity. So if you're super sick in the ICU with ARDS, you should be on some Ampho-B. Some people argue that the newer azoles and mycofungins are more effective. That has not been shown in clinical trials. So maybe they are. Mild to moderate disease, Ampho should work. If you have CNS disease or pregnancy, they're still recommending Ampho-B. Pregnancy, we avoid azoles. They're teratogenic. Okay, Candida. So Candida, unlike all the other fungi I've been sharing with you, they live within us, right? These are normal organisms that live in our GI tract and on our skin. So unlike all the other ones, which we tend to inhale from the dirt and the soil, this one we just carry with us. So it is estimated that they are responsible for 12% of all bloodstream infections in hospitals in the US. There are over 165 species that have been identified, and that number grows every year, but only a few are pathogen in humans, with albicans way out in front. Here's some glabrata, Peropsilosis, tropicalis. So these are less common forms of Candida that can grow. Here's a question for you. Which of the following is a risk factor for development of Candidemia? Candidemia. Parental nutrition, acute renal failure, MRSA colonization, patient, recent recipient of fluconazole for vulvovaginitis. D, all of the above. This one's easy. It's all of the above. Plus trauma. Oh, and colonization with Candida. Oh, and diabetes, and neutropenia, and malignancy, and pancreatitis, and a prolonged ICU stay. These are all risk factors. That's like everybody. That's everybody we see in the ICU. That's right. And that's why this is a hard one, is because they're sick, they're febrile, we don't know what the hell's going on. Might this be Candida? Yes. And the reason we wonder, and because we can't rely on our blood cultures very much. They're just not sensitive. At most, we are able to pick up half of all Candidemia with the positive blood cultures. It likes to go to, it's not just blood, it likes to go to kidneys, liver, spleen, eyes, endovascular structures if they got a prosthetic heart valve in or some hardware after a hip replacement. And it just likes to go everywhere. You can get super sick with peritonitis, meningitis, and then we get confused because we'll get something grow off of a BAL or it's in the urine, right? And you look at those and go, well, is that a real pathogen, or is that just colonization of those two organ systems? And it can be really tricky to tell. Most of the time, I think I've got this on the next slide. I'll cover it in a second about how we sort through that. Let's go through some of these manifestations. So classically, it's a fever that doesn't respond to broad spectrum antibacterials, I should have there. You have catheters that sit in there a long time. Several of those major risk factors I mentioned. Multi-organ systems that seem to be involved with an infection. And then you can see these lesions on the skin. This is a great picture of them. These are nodules. They're bumpy and red and can hurt, but not always. And then we have the Candida endophthalmitis. So this is sometimes we'll bring ophtho by, not just to look at the retinas to see, hey, do you see fungus in there? Because if you know they have fungus, we still like ophtho to come by because it influences the duration of therapy. So not just 2 weeks, we meant 6 weeks when you've got retina involved. So the diagnosis, I mentioned that the blood cultures miss probably half. We often will do fish assays to help differentiate albicans from non-albicans species. We have fungitel assays, which are okay in their performance, but again, you can't rely on them in really sick patients, and it cross-reacts with some other things. And we're going to come to the role of T2s in a bit here. Here's a question for you. Which of the following statements about Candida prophylaxis in the ICU is incorrect? Okay, which one's incorrect? Daily bathing with chlorhexidine can decrease candidemia. Daily bathing with chlorhexidine can reduce ICU mortality from candidemia. Prophylaxis of fluconazole in high-risk patients can lead to drug-resistant strains of Candida. Delayed antifungal therapy for candidemia is associated with higher in-hospital mortality. Most ICU patients with Candida isolated to either urine or sputum do not need antifungal therapy. Which of those 5 statements is wrong? So 4 of them are correct. This one's harder. And here's a little tip. When you don't know the answer to a board's question, say, okay, if I were in the unit, what would we do? And you're probably going to be right. So what would you do based on how do we do daily bathing with chlorhexidine? No, not in every patient. We clean sites with chlorhexidine, but I'm talking total body skin baths. We don't do that. Does it reduce candidemia? Yep. It just doesn't cause any improvement in ICU mortality. That's why we don't do it. So the incorrect statement is 2. Okay, that's the incorrect statement. It doesn't reduce ICU mortality from candidemia, but it can reduce candidemia. Okay. Prophylaxis does lead to resistance. So that liberal use of, oh, we just gave them some fluconazole. Great. Okay, maybe, but then 2 weeks from now, they're going to have a resistant strain that you're going to be dealing with. But then again, if we miss it, if we delay our diagnosis and treatment of true candidemia, those people do worse. And that's what's hard about this infection. But clearly, most patients who have Candida isolated to either urine or sputum don't need therapy. Years ago, we used to have a kind of a staining protocol here. If it was isolated from both, then we'd give them, some fluconazole for a week. We still do that? Is that pretty much the standard?
No, I don't. No, it was when I was here. We did what you said.
Yeah.
I don't know.
So now when we colonize it, when we get it in both urine and sputum, do we just watch it? I don't know. My first go around here at Henry Ford, we would treat with fluconazole for a week. At Indiana, we would. It's kind of local culture in terms of how you want to approach it. It's a threshold for how, do you want to treat it and risk over-treatment and future resistance, or do you not treat but also risk that you might miss a candidemia now and then? That's what's hard. But most don't need it. And if it's isolated one or both, a lot of ICUs will use it if it's in both at the same time. So best steps, get rid of catheters. The echinocandins preferred over azoles as initial therapy. This is playing an increasing role when we just don't know. And that's because, we don't know what Candida species it might be. If it's albicans, the azoles are probably just as good. It's when it gets to be some of these other Candida species that the azoles may not work with. Duration 2 weeks after negative blood cultures. So you watch it until they become negative, and then plus 2 weeks. And as I mentioned earlier, if you've got retinal involvement, it's at least 4 to 6 weeks of treatment. And again, the prophylaxis, there's inconsistent literature. And then we just talked about 1 week if it's in 2 or more sites. So we have T2 here at Henry Ford. Most institutions don't use T2. And so these are clever. This is a very clever assay. And I think basically it can be, when it comes back negative, it's an extremely useful test, so you don't need to use empiric antifungal therapy. So we're pretty lucky here that we have it. Some hospitals have picked it up and then they drop the test because I'm not quite, I think it's expensive, and it does get ordered a lot. So, is it going to be coming like a procalcitonin, a BNP? You walk through the door, you get your T2, and so, I don't know. It's just, it gets used a lot. We spend a lot of money on this. Candida auris. So this is one of these scary new emerging pathogens that's spreading in healthcare centers, and it can be misidentified. And the problem is, it's resistant to so many antifungals. It's resistant and it can spread. So this is one. This kind of thing that shows up in your newspaper. Crazy. No antibiotic can treat this infection. Blah blah blah, and the public gets all riled up, and maybe they should. But this is concerning, and there's likely going to be more like it. Oh, Coccidioidomycosis. Okay, I'm not gonna go past 2, so we'll just see how many of these we can get through. We don't see this much here in Michigan, but you might see it on your boards. Now, if you happen to be, you talk to your friends who might be pulmonary critical care fellows in Arizona. This is like water in Michigan. This is everywhere. And there they call it valley fever. Have you heard that one? A desert rheumatism. So this is a fungus that grows in the soil, endemic in this part of the United States. So again, we inhale it, and most people who get it don't get sick, or they get very minimally sick. 60% are asymptomatic. There seems to be this weird ethnic predisposition. Filipinos and African Americans are more likely to get it. That's the kind of thing that shows up on a board exam. And again, most are self-limited and you don't need to treat. So you come in, they say, yeah, this is desert fever. Go home, come back if you get worse. So it's not a reflex that you have to treat. Histo's like that too. The clues that it's not a community-acquired pneumonia is if you have hyaluradenopathy, eosinophilia, or skin manifestations, classically erythema nodosum. These things go along with coccidio. So if you see that, that's your clue. And so the clinicians out in Tucson, they see this so much, that's what they look for, and they will select antibiotics. They might say, we're going to skip antibiotics because this is not pneumonia, this is cocci. So there are some antibody testings you can do, but there's antigen testing that are becoming more and more useful. Again, it cross-reacts with histo and blasto. Those little spherules I showed you on the other one, that's great if you can see it, and it also grows easily when you are able to see it. But don't rely on just one of these. You probably, like with blasto, a combination of diagnostic criteria. Most patients you can just observe. You don't need treatment, but if you're immunosuppressed, fluconazole, maybe ampho if you're really sick. That's coccidia. Cryptococcus is it's a different type of a fungus we think of in different populations. Again, it's worldwide in the soil, and birds are vectors as well. Immunocompromised hosts typically, so usually you have to be sick to get it. And it loves to involve both lungs and CNS. So you see it in the lungs, think of it's in the lung, in the brain, and vice versa. So typically we'll do BALs or pleural, run it on pleural effusions, and CF will look for the antigen detection. Treatment, fluconazole, but if you've got brain involvement, you need ampho and flucytosine. Cryptococcus gaddii, this is a different one. This one's along the Pacific coast. These people in subtropical regions. And it can be a little tricky to treat and diagnose, and it's difficult to differentiate histologically from neoformans. Histo. I was looking at this map this morning, getting ready for this talk, and I'm really goes, gosh, look, they're leaving us out here in Detroit. We see a little histo here, right? But when I was in Indiana, it's just like, it felt like we were the epicenter. Us in Nashville at Vanderbilt, we feel like everybody's got histo in Indiana. In fact, I suspect that if you shot chest x-rays of all Hoosiers over the age of 30, half would have little pulmonary nodules that are from histo, which makes lung cancer screening a real challenge. Seriously. Again, it's in the soils, it's bird and bat droppings, transmission. Let me get this thing out of the way. We breathe these in. The classic questions on boards, will tell you about a patient who has a hobby. They have a chicken coop, or they go spelunking and hang out in caves and things like that. Those are buzzwords for think histo. The boards have caught on. They stopped using those obvious things, and there's obviously most people get histo from things other than chicken coops and spelunking. Oh, it's frozen up on me. There we go. So again, like Cocci, it's usually very mild infection, very self-limited. You don't need to treat it in just about everybody. Although when you do get sick, it can typically it's diffuse infiltrates. The nodules on CT scanner can be PET positive, which again makes lung cancer screening difficult. This is active disease, not old burnout disease. They can get bronchiolithiasis and some fibrosing mediastinus. I'll show you a couple pictures of those. The key ones you got to worry about are the HIV risk factor patients, the HIV risk that go with histo. Something about HIV and its immunosuppression, histo just takes advantage of. And before we had good fungal, this is one of the leading causes of direct death in HIV patients was histoplasmosis in this region of the country. And who gets it depends on, and who gets sick is a combination of the intensity of the exposure, your immune status, just bad luck. There was a house staff at Indiana University a number of years ago who developed fibrosing mediastinus from histo. Perfectly healthy guy. Came in, presented with SVC syndrome. It was, and then, I'll show you, I think it's on the next slide. Here's a picture of it. So you can see all this inflammation of these flecks. This is calcium deposits. It surrounds your aorta. It presses in on your SVC, and it's like a hard plastic cement material. And years ago, surgeons would try to go in there and just, debulk it, debride it. It's like they said, you need like a hammer and chisel. And you're doing that next to a big pulmonary artery. So it's a huge problem. You just hope there's some collaterals that form and this thing settles down, because you don't know who's going to get this and who's not. There's nothing really you can do about it. The other problem that they get is bronchiolithiasis, and this is where they basically look like you're eroding calcified nodes. Here's one endobronchially, and you can see the CT, how just is nearly completely occluding the left main stem. Antifungals don't work in this. This is not an active infection. This is old calcium fibrotic material that gets hardened and just erodes its way across into the airway. I am inclined to stop here because it's 2 o'clock. Again, treatment for histo is usually observation, intrafremata, info when you're real severe. At some point, if you guys want me to continue on with this at a later date, I'm happy to finish up this presentation. It's designed, it can be divided up into lots of different compartments and modes. So it's not like I have some final end summary that I want to give that ties it all together. It's a lot of little facts combined together. So I'm going to stop there because it's 2 o'clock. Any questions that I can try to answer? Okay, I think, I mean, this is easy. You guys can have these slides. I don't know the best way to post them. We save them. I can email you those. Okay. All right. I'll stop there. Thank you, guys.
Thank you very much.
And I have to do the board lecture. They gave me 40 minutes. So I try not to be